All right. Good morning. My name is Cassie Culliff. I'm a pharmacist at Amplify Health Gunderson Region. Thank you for joining us this morning. This session is designed to engage pharmacy students and pharmacists in the critical care and acute management of hyperglycemic emergencies. Please note that this session is not accredited for pharmacy technician continuing education. Today's presentation will outline key elements of an evidence-based fluid management strategy for patients experiencing hyperglycemic crises. You'll also explore strategies for the early use of subcutaneous insulin and review appropriate treatment approaches for managing euglycemic diabetic ketoacidosis. We're pleased to welcome today's experts presenters, Janelle Jewell, Liz Lawback, and Sarah Peppard. Sarah Peppard is a board-certified critical care pharmacist and pharmacotherapy specialist who serves as professor of pharmacy practice and assistant director of experiential education at Concordia University, Wisconsin School of Pharmacy. She also practices as a critical care pharmacist in the medical intensive care unit at Froedtert Hospital. Liz Lawback is an assistant professor of toxicology at Concordia University, Wisconsin School of Pharmacy, and a clinical toxicologist at the Wisconsin Poison Center. With a background in EMS, inpatient pharmacy, and leadership, Liz brings real-world insight to her teaching and a touch of humor through her course mascot, Meth Cat. Janelle Jewell is a clinical pharmacist at Froedtert Hospital, where she primarily practices in the cardiovascular ICU and serves as the clinical pharmacy coordinator for solid organ transplant, cardiology, and ICU services. A 2014 PharmD graduate from Concordia University, Wisconsin, she completed both PGY1 and PGY2 residencies at Froedtert in acute and critical care. Full speaker bios are available in the conference app. Please join me in welcoming them.
Great. Good morning, everyone. Thank you, Cassie, for that introduction, and thank you all for being here. We are, on behalf of Janelle, Liz, and I, we're excited that you decided to come and learn a little bit more about DKA. During our time together today, we're going to do a brief overview of DKA management with kind of a focus on fluid therapy. Janelle is going to cover use of subcutaneous insulin for DKA, and then Liz will round us out with a discussion on euglycemic DKA. So welcome, and we're excited you're here. None of us have financial relationships that need to be disclosed, and our learning objectives are listed for you on the slide. We would like you to be able to outline the elements of an evidence-based fluid management strategy for a patient with a hyperglycemic emergency, describe strategies for appropriate implementation of early subcutaneous insulin use in hyperglycemic emergencies, and then identify appropriate treatment strategies for patients with euglycemic DKA. So for my portion of our discussion today, I'm going to focus on an overview of DKA management. In 2024, so last year, ADA released an updated guideline on management of hyperglycemic crises. Prior to that, we were operating on a 2009 guideline. So not a ton has changed in the management of DKA, but there are some elements that I will point out during the overview where there are changes. So I'll highlight those as we talk through our discussion through my portion, but the focus will really be on some of the literature related to fluid therapy. So diabetic ketoacidosis and hyperosmolar hyperglycemic state are really life-threatening and complex metabolic dysfunction due to either the relative or absolute lack of insulin. So this, which isn't enough insulin for your body to suppress hyperglycemia, as well as ketone production, as well as the increase in counter-regulatory hormones, leads to these complex metabolic disturbances. In the setting of DKA, thankfully mortality is overall pretty low. It is a treatable and preventable complication. But one interesting thing to note is the incidence of DKA hospitalizations has been on the rise. And there's a number of different proposed reasons for this. One is just the increased incidence of diabetes, and also the increased awareness and diagnosis of diabetes, that it's being presented and being treated more often. This slide is quite busy, but I wanted to just sort of remind everybody about the pathophysiology of this disease state. So DKA is really characterized by three criteria: hyperglycemia, ketone production, and metabolic acidosis. So looking on the left-hand side of the slide, you'll see that absolute insulin deficiency, which is really the case within DKA, or typically more common with type 1 diabetics, that leads to lipolysis, free fatty acid production, and the production of ketones, with beta hydroxybutyrate being the most prominent ketone produced during DKA. This hyperglycemia that results from a lack of insulin also leads to kind of a vicious cycle pictured in the middle of the slide, where you have volume depletion due to osmotic diuresis, and you also have impaired renal function. It tends to lead to like a pre-renal AKI. And then hyperosmolarity can develop more commonly in the setting of HHS, where you have often you have enough insulin to prevent ketosis, but not enough to manage the hyperglycemia, and you get more profound dehydration in the setting of HHS. So this slide kind of depicts the same pathophysiology, but it does also point, since we're talking about fluid therapy and kind of focusing on fluid therapy, I wanted to highlight that you have this osmotic diuresis and volume depletion that happens as a result of that hyperglycemia. But also common in the setting and presentation of DKA is nausea and vomiting. So you can also have volume loss from the GI tract as well, which can further complicate and lead to mixed acid-base disorders. So how do we diagnose DKA? You need all three elements. So you need the diabetes or the hyperglycemia, ketosis, as well as metabolic acidosis. One important update with the 2024 guidelines is that the blood glucose cutoff was actually lowered. So historically, it was a blood glucose greater than 250 milligrams per deciliter. Now it's greater than or equal to 200, or a history of diabetes. So this is really important, and I think this sets Liz up well for her section. About 10% of patients that present in DKA have euglycemic DKA. So really lowering those thresholds and bringing awareness to the fact that you don't have to have profound hyperglycemia to be in DKA. Ketosis is the second component needed for a diagnosis of DKA. You can see the 2024 guidelines did adopt beta hydroxybutyrate, which is the most prominent ketone produced in the setting of DKA, and the threshold that they're looking for is greater than 3 millimoles per liter. The 2029 guidelines really relied on the ketone productions and ketone strips. So this is kind of a new use of beta hydroxybutyrate is kind of a newer thing that has come out with the recent guidelines, and there is some pretty solid data behind the use of beta hydroxybutyrate. Just out of curiosity, for those in the audience, how many are at institutions that are obtaining beta hydroxybutyrate levels? Okay. So it is sort of newer. It's not all across the board. You can still use the urine ketone strips, and I'll talk through some of the differences of those tests on the next slide. And finally, the presence of acidosis. So this is defined as a pH less than 7.3 and or a low bicarbonate. And the big change here from the 2020 or from the 2009 guidelines is the elimination of the anion gap. And we'll talk through a little bit why the anion gap isn't always very reliable. We have patients that have kidney failure and things that chronically have an anion gap, and you're never going to normalize their anion gap. So it can be a challenging marker to chase in our DKA population. Talking in a little bit more detail about the ketones. So there are two different ways we can measure ketones. You can measure acetoacetic acid using urine or serum sodium nitroprusside reaction test, which is a semi-quantitative test. And it can, because it is measuring the acetoacetic acid, and beta hydroxybutyrate is your primary ketone, it can underestimate severity in early DKA due to the lag in production of acetoacetic acid, and then overestimate in late DKA, where more of that beta hydroxybutyrate has been converted to acetoacetate. We also do have some drugs that can interfere with the test. Valproate has a ketone metabolite that can cause a positive test, and any drugs that contain a sulfhydryl group, such as captopril, can react with the reagent and also produce a false positive. So for some of these reasons, beta hydroxybutyrate has been gaining some steam and some popularity. It's quantitative versus the semi-quantitative, and the data out there shows that levels of greater than or equal to 3 has a 90% sensitivity and specificity for the diagnosis of DKA. There is point of care testing as well as a lab draw that can be utilized for this. So putting this all together, we need those three elements of diabetes, ketosis, and acidosis to diagnose DKA, but then you can further categorize it based on severity. And really the severity is looking at the degree of ketosis, so the degree or level of beta hydroxybutyrate, and the degree of acidosis. Also important is mental status. So you'll see more severe patients are going to can present with more severe mental status changes related to their severe acidemia and bicarbonate levels being very low. So these are the types of patients I tend to see, the moderate to severe patients I tend to see. Janelle will be focusing on some of the other earlier DKA patients that we can this is helpful to classify patients and determining which patients need to go to which level of care. So there are four main tenets in the management of DKA: fluid replacement, insulin therapy, electrolyte repletion, and treating of the precipitating event. So this is due to typically infection. If you work in Janelle's area, surgery or MI can also precipitate an event. So there are lots of causes, and that, you can't forget about treating what is causing it. For the purposes of today, we're really going to focus on, in my section, I'm going to focus on the fluid replacement because that's where some of the more recent literature has been. Thinking back to that very complicated pathophysiology slide, fluid therapy is so essential because it really hits multiple areas of the DKA metabolic processes that are happening. So restoring intravascular volume, by doing that, you're increasing organ perfusion, restoration of blood flow, helping with that AKI that frequently develops, increased clearance of glucose as well as ketone bodies. It can help to correct those electrolyte disturbances, decreases plasma osmolarity, and also diluting out those counter-regulatory hormones and decreasing those helps our insulin work. So fluid therapy is very important and is really the first step. So we need to get insulin on board. We need to get fluids on board when these patients present to us. Looking at what the guidelines recommend, you do have to do a patient assessment to determine their degree of volume depletion to understand how much volume they need. And this is something where you kind of set it and forget it. You're assessing them, giving volume based on kind of their presentation and how they're progressing. So depending on the degree and the hydration status, the guidelines recommend 500 to 1,000 milliliters during the first 2 to 4 hours. So at a minimum, patients are typically receiving a couple of liters of fluid right off the bat to help with that volume depletion. Often a maintenance rate is started beyond those boluses to help again with that continued replacement of volume. We do have to be cautious in patient populations that are at risk for fluid overload. So this isn't, fluids are a drug. We don't want to just not think about it and willy-nilly give patients fluids. You can cause more harm than good in the setting of heart failure or kidney disease, frail or older adults, pregnancy. Those are patient populations where you want to be a little more cautious and do more frequent assessments. The goal is to really collect the fluid deficit over the first 24 to 48 hours. And then it is important to note that when the patient's blood sugar drops to less than 250, we do need to add dextrose to those fluids. They still need insulin. They are still in DKA until the ketosis has resolved. And the only thing that fixes ketosis is insulin. So you need to continue to give insulin even if the blood sugars are low. So that is kind of the trigger to add dextrose to the IV fluids. All right, so which fluid to give? If you look at the guidelines, they say 0% normal saline or other crystalloid. And if you look at the British guidelines, they recommend 0% normal saline. So, with that being said, there has been a push to determine should we be using balanced solution versus what the providers in my unit like to call abnormal saline. So if you look on the table there, we have human plasma on the top row, followed by normal saline, and you can see normal saline is not very normal. The sodium content is abnormal. The chloride content in particular is very abnormal. Um, and if you look at lactated ringers or plasma-light solution, those are more physiologic. Those are more similar to human plasma. So the thought is, what the research question has been, what if we give patients balanced solution versus normal saline? Does that impact outcomes? Now, if you're practicing the critical care setting, this has kind of been a real hot button topic lately for other like sepsis and another fluid resuscitation states. And there really has been some good literature coming out that does show that balanced solutions tend to be a little bit more safe. They prevent the development of hyperchloremic metabolic acidosis, so a non-anti-GAP metabolic acidosis that has been associated with acute kidney injury and complications. So by being more mindful of the solutions we select up front when we're volume resuscitating patients, we can potentially prevent some complications down the road. So what does the literature look like in the setting of DKA? Well, here's kind of a summary table of a number of the studies out there. I'm not going to go into a ton of detail about each of these studies, but I want to highlight a few things for you. We have some randomized controlled trial data, but if you look at the N in those studies, they're pretty small. They're pretty small RCTs. So that's one thing I wanted to highlight. The other thing I want to highlight is the primary outcomes vary quite a bit from study to study. And as I'll talk about a little bit in a couple slides, time to DKA resolution can be defined different ways, and different studies have defined it in different ways. So that's kind of a moving endpoint, and that can be tricky to decide if it's really meaningful. And in clinical practice, I know I see a lot of people, they're, they resolve DKA, but then they get transitioned a little bit early, and then they end up they're not totally feeling better, and we kind of regress. So it's sometimes a moving endpoint. Within this, so if you look at the time to resolution of DKA, that seems to be kind of a common theme. And if you dig deeper into each of the studies, some of them used a bicarb cutoff of 18. Some of them used a bicarb cutoff of 15. Some of them used an anti-gap less than 12, or a combination of those criteria. So it is a little bit of a moving target. Looking at incidence of hyperchloremia, that if you give normal saline, you're going to have an elevated chloride. So obviously those studies did show a difference. So there is some questions about what is the best outcome to look at in these trials. We do have one meta-analysis in this space looking at the RCT trial, and it includes 8 randomized controlled trials that compared saline to balanced crystalloid. And they did show that overall balanced solution shortened time to DKA resolution, which ultimately translated into a shorter length of stay. Now, when you look at the individual studies and the degree of the difference in time, it was typically about 2 to 3 hours, the difference in DKA resolution. So that can be meaningful in a hospital setting. The saline group tended to have higher post-chloride levels, and it looks like my serum bicarb was cut off, but lower serum bicarb in those studies compared to the balanced solutions. So to summarize fluid therapy and where we're at, balanced solutions have been associated with shorter time to DKA resolution, although I kind of highlighted that was sort of a moving target and different depending on the study you looked at. Less hyperchloremia, less AKI I would put as a question mark. Only 3 of the trials really looked at AKI and didn't find a huge difference, and that was really most of these patients present in AKI, so it's hard to know. There wasn't a lot of need for new renal replacement therapy, and they tend to resolve their AKI quickly. So whether or not A balanced solution really helps with AKI is still kind of a question out there. And then the shorter ICU and hospital length of stay. I do want to also highlight the limitations. Small RCTs, a lot of the larger trials were observational in nature, and we did have differing primary outcomes. And I'll kind of close our discussion out today by a discussion of resolution. So that time to resolution of DKA, there are some differences between the guidelines and what they define as a resolution of DKA. You can see with the 2024 update, we're looking at plasma ketone levels and a resolution of the acidemia. So pH greater than 7.3 or bicarb greater than 18. That is a change from the 2009 guidelines that looked at that blood glucose value, and then two of the following criteria there where the anion gap is listed. And you can see that the anion gap was removed because it can be misleading due to the presence of hyperglycemic metabolic acidosis. We do chloride load these patients. That can impact your anion gap. So that is something to be aware of and why it's kind of been removed from the more recent guidelines. So with that, we're going to jump into our first learning assessment question. Compared with sodium chloride, the use of balanced crystalloids for fluid therapy and DKA management is associated with A, longer hospital length of stay, B, higher incidence of AKI, C, higher post-resuscitation serum chloride, or D, shorter time to DKA resolution. All right, very good. So the answer is D. So really that's where we have the strongest data now is for the DKA resolution. The trends are towards the opposite of the other responses there. All right, I will hand things over to Janelle to talk about subcutaneous insulin protocols.
All right, let me just get situated here. All right, great. Thank you, Sarah, very much for that introduction and brief overview of the management of DKA and fluid therapy in DKA. I am going to jump right into talking about the use of subcutaneous protocols for treatment of DKA. And so as Sarah mentioned, insulin is a cornerstone in the treatment of DKA, and insulin therapy should really be started pretty immediately after the diagnosis of DKA. Our 2024 guidelines that Sarah introduced us to do make a statement in there that the initiation of IV insulin given continuously is actually the preferred choice. However, given this differing severities of DKA, we do have another option, and that leads us to our subcutaneous DKA protocol discussion. A couple other reasons why you should consider the use of subcutaneous DKA treatment or insulin in DKA treatment is the possibility of reducing the need for an intensive care ICU admission, decreasing nursing workload. When you start insulin in the continuous form, you do have to do every 1 hour blood glucose checks, whereas with subcutaneous DKA, we definitely do have to monitor, but it's less frequent. And then also there's been several studies and a couple meta-analyses that have been completed looking at the difference between continuous IV insulin and subcutaneous insulin protocols. And what they've found so far is that when you utilize a rapid-acting insulin analog in combination with long-acting insulin, it is very similar to how IV insulin in the continuous form performs. And so that leads us to think that if the subcutaneous DKA protocols are just as effective as the IV continuous insulin, we could potentially use them for treatment of mild to moderate DKA. So I'm going to briefly touch on the two different meta-analyses that were performed. I thought this was the best summary of the available evidence that we have. The first one was a Cochrane review that was published in 2016, so a little while ago now. What this looked at was 5 randomized controlled trials, so only included randomized controlled trials, really excluded any type of observational study. There were 201 study participants, and of those participants, we had about 91 of those get IV insulin and 110 get subcutaneous insulin. All of the trials utilized definitions for diagnosis of DKA that followed the American Diabetes Association definitions. And then it included mostly adults. So in this particular review, younger adults and children were definitely underrepresented. The most common reason for DKA was noncompliance with home regimens. And the outcomes that they utilized in this particular Cochrane review included the time to resolution of DKA, hypoglycemic events, and then also mean hospital length of stay. What you'll see here on this slide is that one of their outcomes looking at the time to resolution of DKA, which Sarah also talked about when she talked about her fluid studies, there was no difference in the time to resolution of DKA within those randomized controlled trials when they looked at them together. There was also no difference in hypoglycemic episodes or mean hospital length of stay when they looked at the 5 randomized controlled trials. So what this 2016 Cochrane review determined and concluded was that really there was no advantage to the use of subcutaneous insulin, but there also was no disadvantage to the use of subcutaneous insulin in those patients that had mild to moderate DKA. So given that that was done in 2016, and as I mentioned, it excluded observational studies and only included randomized controlled trials, and given the time from 2016 to 2024, there had been additional studies that had been completed. There was another meta-analysis that was done in 2024. And so I wanted to highlight this one as well, as it's a little bit more recent and includes more studies. This meta-analysis includes 6 randomized controlled trials. With those 6 trials, we had about 245 total study participants, so a little bit lower of an N, and 4 observational studies. There were almost about 8,500 study participants within the 4 observational studies. Similarly to our previous meta-analysis with the Cochrane review that we looked at, they also all of these trials utilized the definition from the American Diabetes Association for the diagnosis of DKA, so that was also consistent. They also looked at very similar outcomes with this meta-analysis compared to the Cochrane review as well. And so you'll notice that the outcomes that they reviewed were time to resolution of DKA, hypoglycemic events, and mean hospital length of stay. So this meta-analysis also concluded that there was no difference in the time to resolution of DKA when they looked at all of the studies together. And then also, same as our 2016 Cochrane review, there was also no difference in any hypoglycemic events. Where this meta-analysis and the results differed a little bit from the 2016 Cochrane review was that some of the individual studies that they analyzed did identify a decrease in hospital length of stay. And also we had one study that looked at the duration of stay in the emergency department, and that study found a difference in that length of stay in the emergency department as well. So this meta-analysis did want to highlight that some of those studies did find those differences. However, when they looked at it all together, they found that there was overall no difference in the length of hospital stay. So what this meta-analysis concluded was that the treatment of DKA with subcu insulin could definitely be a safe and effective alternative to the use of IV continuous insulin. And so again, leads us to think that we could use subcutaneous insulin in patients with mild to moderate DKA to help us simplify therapy, avoid ICU admissions, and potentially, because some of the studies saw this, decrease our overall hospital length of stay. So when should we use a subcutaneous protocol for our patients? So Sarah did a really great job of highlighting the diagnostic criteria for DKA. And so this table is very similar to the one that she previously showed us. What I wanted to highlight here is that severe DKA, those patients will still necessitate the use of IV continuous insulin, and those patients will also require an ICU admission. So those are the patients that Sarah sees and we treat in our medical ICU. The subcutaneous protocol is really most appropriate for mild to moderate DKA. And in all of the studies that we looked at in the 2 meta-analyses, the majority of those patients that they were comparing were in the mild to moderate DKA category. So that's why we feel like we have the most evidence for those particular groups of patients. So just to review again, the kind of cutoff that we're looking for severe DKA versus moderate DKA is looking at that beta hydroxybutyrate. Once you pass the threshold of greater than 6, you're now in the severe category. So patients that are less than 6 could be considered for a subcutaneous protocol. And then also looking at the pH listed there. And so once you get below a pH of 7, again, you're moving into that severe category, and you'd no longer be appropriate for a subcutaneous protocol. One thing that I did want to highlight on this slide is that these are the definitions and how we diagnose DKA from the 2024 guidelines. What I have found in the development of our institutional subcutaneous protocol and looking at other institutional subcutaneous protocols is that institutions do sometimes differ in these criteria, especially with the pH. So I did include a statement here that institutional pH values for the diagnosis of mild to moderate versus severe DKA might differ depending on the institution. And the reason for that is really so that we can make sure that we're giving our patients the most appropriate placement. And so for us at our particular institution, for example, we would not want a patient with a pH of 7 going to our step down unit. That patient would end up going to the unit. And so we did a more conservative pH cutoff so that we were not having patients that were on the border of moderate to severe or on the more severe end of the moderate diagnostic criteria. So some of those protocols get modified just to be a little bit more conservative for the patient care. So that leads us again to the severe DKA, which is when we should be using our IV continuous insulin. So that's just the diagnostic criteria for DKA, which again is pretty straightforward and set up for us. But I did include some other indications when we could maybe consider that even if our patient was in the moderate category and had a pH of 7.25, for example, and was not altered. If they had any of the following things in the blue box, we would really maybe reconsider them being appropriate for a subcutaneous protocol and a step-down unit admission, and they might be more appropriate for the IV continuous insulin and ICU admission. So those things listed here include any patient that has end-stage renal disease, if we have patients that have advanced liver failure, those that have hypovolemic shock, so if they're very dehydrated, for example, any hemodynamic instability, if a patient is in a comatose state or altered, those patients also would be more appropriate for an ICU. Acute myocardial ischemia, again, if that's the precipitating event for the patient being in DKA, then that patient would also be more appropriate for IV insulin, and they would go to the ICU. Acute heart failure, pregnancy is also listed, so those patients automatically are excluded as well. And then one thing that I like to point out is you could have a patient that is, again, meeting mild to moderate DKA criteria, but they are very fluid overloaded. And so those patients, if we think about the pharmacokinetics and the administration of subcutaneous insulin, it definitely could be altered in those patients. And so to get the most effective treatment in any patients that are fluid overloaded, we would want those patients to be on IV insulin and have an ICU admission as well. This is taken directly from the guidelines. I just redid their algorithm a little bit, but I did want to walk through a brief walk through the subcutaneous protocol and what the guidelines recommend quickly. The fluids, Sarah already did a wonderful job of explaining to us, so those are just on the slide for completeness purposes because they should be part of your therapy, even in a subcutaneous protocol. And then for insulin, the guidelines do recommend you give a bolus. Previous guidelines and literature had supported a bolus of 0.3 units per kilogram subcutaneously. The guidelines now have decreased that bolus recommendation to 0.1 units per kilo. And then after you give the bolus, you'll initiate 0.2 units per kilo every 2 hours subcutaneously. The guidelines also do suggest that you could use 0.1 units per kilo every hour. But I'd have to say, in terms of the protocols that I've been a part of in development, the 0.2 Q2 hours is far more popular. I do think that goes back to kind of what we were talking about being able to place these patients in a non-ICU area and having the nursing workload decrease a little bit with less frequent glucose checks. You would also initiate your long-acting insulin, and then a couple of the other supportive care things that we'd always want to check on, even with the subcutaneous protocol, include potassium, phosphorus, and magnesium. You want your hypoglycemic protocol there, and then some of those monitoring parameters. Sarah did a really great job of talking about beta hydroxybutyrate and how that's been a change to the guidelines in terms of diagnosis, and also for when we look at the resolution of DKA. It's also been a change for when we are monitoring our patients as well, right? Obviously, if we're going to use beta hydroxybutyrate to determine if DKA is resolved, we have to monitor it throughout the protocol. And so most subcutaneous protocols will ask for a beta hydroxybutyrate every 4 hours. Once your blood glucose is less than 250, you are going to want to add that dextrose to the fluids like Sarah had mentioned already. But with subcutaneous protocols, you take your dose that you were giving and you essentially cut it in half, reduced by 50%. So if you choose the 0.2 units per kilo every 2 hours, once the blood glucose is less than 250, you reduce that to 0.1 units every 2 hours. And then you continue that until you have resolution of DKA. The guidelines do include a recommendation. I know that for the diagnosis of DKA, the cutoff was now 200. They recommend that your target glucose during treatment with a subcutaneous protocol is between 150 and 200, which is a relatively tight range to meet. But as long as you're less than 200 is a good goal. So for resolution of DKA, this is the same as what was on Sarah's slide as well. So for any type of DKA, whether we're treating mild or moderate or severe, we're looking at the same things for the resolution. So just to re-highlight some of those, we have a patient would have to have a pH of greater than 7.3 or a bicarbonate of greater than 18, and they have to have a beta hydroxybutyrate that level that is now less than 0.6 millimoles per liter. And so again, just to remind you, most of those patients for the cutoff were above 3 for the beta hydroxybutyrate. So now they have to have a level of less than 0.6. Some other things that I always like to include is even though we're looking at those criteria, we still have to use our clinical judgment to determine if the patient symptomatically feels better and is ready to have a diet. And then once the diet is ordered and we have assessed all of our parameters and everything looks good to transition, we will order their home insulin regimen and initiate a basal regimen if it hasn't already been initiated. Or if they're not on something at home, you do the long acting and the prandial rapid acting insulin as well. So that concludes the information about the subcutaneous protocol. The learning assessment question that I have is just to help us figure out maybe what type of patient would be most appropriate for a subcutaneous protocol. So which of the following patient criteria would be appropriate for implementation of subcutaneous insulin use? Would you be okay with a patient with a pH of 7.1 that's altered and has a beta hydroxybutyrate of 6.1 utilizing a subcutaneous protocol? No. Okay, good. That patient should go to Sarah. She should take care of that patient. And what about a patient that has a pH of 7.27, is alert, has a beta hydroxybutyrate of 3.4, but has significant volume overload? No, good. I see a couple of people shaking their head. This patient meets criteria for mild to moderate DKA based on their pH and the beta hydroxybutyrate, but it's that significant volume overload that if they go to the floor and we try to give them subcutaneous insulin, we might end up having to escalate their care to IV use anyway, just because the change in the absorption of the sub-Q insulin. C is pH of 7.3, alert, your beta hydroxybutyrate is 3.7, and your patient is hemodynamically stable. Yay, getting a lot of aggressive head nods. That's good. This is a really good patient to go to a progressive care unit or a step-down unit and initiate the subcutaneous protocol on. And then that finally leaves D, which we know is already incorrect. Again, your pH is 7. The patient is altered. They have a kind of higher end beta hydroxybutyrate of 5, and they're also in renal failure. So a couple things to consider there for maybe that patient is borderline moderate to severe with that low of a pH. And then the renal failure makes us a little bit more nervous as well. So thank you so much. And I'm going to hand it over. We're going to keep learning here. We're going to talk about euglycemic DKA.
I get to go rogue. So if you have something niche, rare, and weird, it's a good time to bring in the toxicologist, right? So I'm excited to talk to you all about euglycemic DKA. I have a tendency to travel when I'm talking, so feel free to be like, hey, Liz, back to the mic, please. But I'm excited to talk about euglycemic DKA because this is something that both when I'm staffing in the inpatient environment and when we're serving the greater Wisconsin area through poison control that we're seeing more of. So first, I just want to pause and define what is euglycemic DKA. It's diabetic ketoacidosis with a glucose concentration less than 200 mg per deciliter. If you look back in the literature, you'll see some other cutoffs. You'll see less than 250. You'll see just normal blood glucose. But with our updated guidelines, this is what we're defining eDKA as. And again, as Sarah had mentioned, roughly 10% of patients with DKA present with euglycemic DKA. This isn't a new concept. This has been around for a long time, but historically we've thought of it in patients where there's some type of impaired gluconeogenesis. Maybe they're in alcoholic ketoacidosis, maybe they're pregnant. We've seen more eDKA kind of in the height of some of the bariatric surgeries. But now, where we're really seeing it is in its association with SGLT2 inhibitors. And I'm going to talk in detail about that because I think if you can understand a bit about why that's happening with that drug class, it will help you understand a little bit about why we take the treatment approach that we do. But even with our SGLT2s, our Flozin drugs, you might be thinking, well, that's not new. And you're right. Back in 2015, the FDA first started adding warnings about this potential complication with our SGLT2 inhibitor drugs. But as you all know, we've seen a big increase in terms of the prescribing frequency of these medications, especially with the additional indication for heart failure. What I hope you can walk away with from this particular part of the presentation is maybe a few intervention points where you as a pharmacist can help make a difference in eDKA. And one of the things, and I grabbed this term right out of one of the studies, and I just thought this was a fantastic way to set the stage for euglycemic DKA, is the issue that it's a diagnostic dilemma. Diagnosis is often delayed because, as you all know, there are many reasons a patient might be in a ketoacidotic state, right? Metabolic acidosis, there's many, many causes of that, whether we're thinking about infection or in my realm, all the potential toxins. But it often gets missed early on. People just aren't thinking about it. So as a pharmacist, if you're encountering this patient or you're starting to see more of this, one of the first things you can do that's beneficial is whatever providers you're working with is just to put this on their radar that, hey, you might want to think about this as part of your differential because it is so frequently missed or it's found later and then treatment is delayed. And as it's already been highlighted so nicely by Sarah and Janelle, this is also why we've added this prior history of diabetes to the updated guidelines in terms of defining DKA. So there are three mechanisms behind these SGLT2 inhibitors that promote or potentially lead to euglycemic DKA. The first is the one you all know well, the thing that we hope the drug is doing, which it's blocking the sodium-dependent glucose transporter 2, which leads to a reduction in the amount of glucose that's taken up in that proximal convoluted tubule in the kidney. We see an increase in the urinary excretion of glucose, which means we have less in our serum. So great, if that's what we hope the drug does. But it's number 2 and number 3 that are really contributing to these issues around euglycemic DKA. The first is that we've now learned that SGLT2 inhibitors directly stimulate alpha cells of the pancreas. So that leads to an increase in the release of glucagon, and it's going to lead to an increase in lipolysis and ketogenesis. So this is something that we now know about these Flozin drugs, and that's part of the mechanism behind this euglycemic DKA. The third, and this is a more minor mechanism, but I think it's worth noting, is that our SGLT2 inhibitors also can increase ketone reabsorption in the kidney. So you really have three mechanisms that are sort of priming this patient. And if you've encountered euglycemic DKA, or maybe a patient where you thought, yeah, I think this is what's happening here, the other thing you might be thinking about is their renal function too, right? If you have that patient that's presenting and they've got a little bit of an AKI or some type of assault to the kidney, that can kind of prime this too. So again, just thinking that you have multiple organ systems involved with these flows and drugs that might set you up for it. So I included this little summary here, but if you're like me and you enjoy a visual, I try to think a little bit about what's happening where, right? And again, we know in the kidney, it's going to block that reabsorption of glucose, but it's also reuptaking a little bit of our ketones. We're seeing an increase in the breakdown of our adipose tissue, which is going to lead to more ketogenesis through the liver. So we've got several things in play here that can set a patient potentially up for EDKA. So how do we treat it? And I have the easy part here because Sarah and Janelle have set you up so nicely for this. The first is hopefully an obvious one, which is to stop the use of that medication, if that's what's their cause, right? Right now, this is often what we're attributing a lot of the euglycemic DKA to, or these SGLT2 inhibitors. But as I mentioned earlier, there's certainly some others. Resuming after DKA has resolved is not routinely recommended. So I will say that I have seen a mix across the board, because I think you can all think of that really complex type 2 diabetic patient, man, where you have tried a variety of different medications. Maybe you can use insulin with them, maybe you can't. And this has been a drug that has worked really well for them. So it's not recommended because, again, it clearly has primed them up for this euglycemic DKA event. But I have seen kind of a variety of things happen in practice. The second piece is you're going to follow guidelines with one key difference, which has already been highlighted, which is the initiation of dextrose-containing fluids concurrently with normal saline when that insulin therapy is initiated. And hopefully that seems reasonable to you in terms of, hey, they already have a quote unquote normal blood glucose, or at least they're not hyperglycemic. So if we're going to give them insulin, we're going to need to support that. So again, just highlighting here in the guidelines that when you have a euglycemic DKA patient, your approach is really going to be the same. You're just going to need to initiate dextrose-containing fluids at the beginning of your insulin therapy. I think this is a nice moment to pause, though, and reflect a little bit about why you're doing insulin or giving these patients insulin if their blood glucose is normal. And so one of the questions I'll often pose to students on rotation with me is, why is insulin used in the treatment of euglycemic DKA if their blood glucose is normal? And the answer, in a very simple way, is just that we know insulin is needed for more than just glucose reuptake, right? It has several different signaling consequences. Obviously, the increase in the cellular uptake of glucose is the one we predominantly use it for, but it's also going to decrease the activity of lipase. It's going to decrease gluconeogenesis in the liver. It's going to increase the movement of potassium into cells. And that can lead us to some of our pitfalls here, right? So one of the places where I think as a pharmacist, in addition to the intervention of just putting euglycemic DKA on somebody's radar, is the issue of not giving enough insulin. So understanding why you're giving insulin, I think, is helpful if you're educating other members of your healthcare team, right? And what I often see when I'm more in a toxicologist role is that maybe the provider understands, the pharmacist understands, and it's that poor bedside nurse who maybe didn't quite get the whole mechanism behind what we're doing and is going, you want me to give insulin to this patient whose blood glucose is less than 200. And sometimes I've had to make interventions where that was simply they just weren't getting enough, especially from my viewpoint, where we're serving a variety of hospitals across the state, everything from critical access hospitals all the way up to large academic institutions. Everybody's insulin order sets look a little different, right? Maybe you don't have an insulin order set that is primed to help you with euglycemic DKA. If that bedside nurse is following an existing order set, this might not be obvious to them. So I've had situations where patients are getting just baby amounts of insulin because, again, that bedside nurse very appropriately is being cautious and might not be aware of what's going on. So one of the other ways that you can intervene is ensuring enough is being given. If you yourself are feeling a little tachycardic at this idea of giving more insulin, let me reassure you, as somebody who gives extremely large amounts of insulin and calcium channel blocker and beta blocker overdoses, does not raise my blood pressure at all. The second is not giving enough dextrose to maintain recommended insulin dosing, right? So a little bit hand in hand. You need that insulin. You're shifting this patient, their catabolic to an anabolic state. You've got to give the dextrose to support the insulin. The insulin is what they need. You're using it for all those additional signaling consequences, not just the uptake of glucose. So that's really a huge message when I'm educating other members of my team or helping someone maybe bedside who's not encountered this before. And that's really the take-home message to me, is that that body needs insulin to shift from a catabolic to an anabolic state. All right, so that takes me to the end of euglycemic DKA. I've got a quick learning assessment question for you here. Which of the following best describes the difference in the treatment recommendations for euglycemic DKA? A, dextrose-containing fluids should not be initiated. I'm not seeing any nods there. B, dextrose-containing fluids should be initiated at the start of insulin treatment. Seeing some nods, some hands, excellent. And dextrose-containing fluids should be initiated only with intravenous insulin treatment. And dextrose-containing fluids should be initiated only in cases of severe DKA. And you all had it right. Choice B here at the start of insulin treatment. Right. Well, that takes us to the end of our presentation. We've got some time. We'd love to take some questions if you have them. And not just me, Sarah and Janelle will be happy to jump in.